Dr. Maya Doyle, who's from the Children's Hospital at Montefiore, and she's going to talk about bringing adolescent and adults with rare diseases through the times of many changes. And aren't we lucky that we're starting to have to deal with this? So what a great, it's really a positive thing. So, Dr. Doyle, if you want to come.
So you see by the title of my talk, I've got a lot of big words up here. Transmutation, transition, and transformation. And of course, all of those words sort of mean the same thing, which is about change. So we're going to be talking about a couple different kinds of change that I think your communities are experiencing. Just so you know who I am and how I got to be in this game, I am a pediatric social worker. I've worked in kidney disease for the last 15 years. I worked with one particular family with rare disease who sort of pulled me into their world, along with my medical director. And as I went back to school to get my doctorate, I was a social worker in need of a dissertation, and I had my cystinosis community that was in need of some research. So it was a wonderful marriage and a wonderful time for all of us to be able to do some work together. And I actually have some articles coming out in the next month. I actually signed off on the second one last night on the importance of community and peer mentorship for young adults with rare disease, and also about transitioning with rare disease. So for those of you that want to go on Google Scholar and look, those articles will be out there in the next month or so, and I'm happy to talk to you about them. So I use the word transmutation, and I'll walk you through where that word comes from and why. But transmutation is a change or alteration in form, in appearance or nature, especially to a higher form. Why are we talking about this? Well, the term comes from medieval and Enlightenment thought. I was a medieval studies minor before I was a social worker. It was a weird jump to make. But I was really fascinated by these ideas of alchemy, right? That people were trying to understand how the natural world and the human body and their spirituality all fit together. And now we look back at those ideas as being maybe kind of crazy, kind of magical. But at the time, they were really trying to figure out how the world worked and how the body worked. And we think of it as sort of nuts, but people like Robert Boyle, does anybody know who Robert Boyle is? I gave it away. Robert Boyle was the person who really first started talking about the scientific method, how to do science, how to do experiments, to figure things out. That'd be pretty important in our world, wouldn't it? Isaac Newton, y'all know what he's famous for? Apple on the head, gravity, right. So these people that maybe some of their thoughts were kind of, now we'd say, oh, that was just crazy, those things didn't connect. But they were also making incredible advances in understanding how the world worked. So their studies may have failed, their attempts may have failed, but they learned new things that moved us forward in the world of science in lots of amazing ways. And in fact, in ways in understanding modern chemistry. So we wouldn't be here, right, without some of the basic understanding of chemistry that started 500 years ago, more than that. And what I like to point out, and I think we think about this, when we this morning talking about a lot of the issues around drug development, a lot of wrong ideas, a lot of crazy ideas, a lot of mistakes, and a lot of leaps are what get us to innovation, right? When we're able to make a change in medical care, in the treatment for yourselves, for your kids, when we've improved health, we've extended life, because that's often what we're seeking to do, right? We're trying to buy your kids another year, another 5 years, a lifetime, if we can. It's not magic. It takes immense work and immense collaboration, and you are all examples of the hard work that takes. But you make miracles happen by coming together and by advocating for your children and for your communities to make these things happen, to push research a little further, to get people working on these ideas. So there are miracles in this. So that's why I like that connection to alchemy, because it's not all hard science. There is some magic in there that we all pull off in this work. So I read a wonderful book a few years ago, and this is where this term really came to me. It's called Bittersweet. It's about the history of type 1 diabetes. You're like, oh, you're going to talk about this common disease. Well, I grew up with that common disease, so did my mother. And I always really understood that there was a real miracle there that allowed me to be here. And that was in 1922, insulin became available that saved people's lives. Because before that, just like many of the diseases that you all are living with every day, that was a fatal disease. You didn't live long, it was painful, and then someone made a leap and figured out that we could give this drug externally, and it changed people's lives. And this book also talks about the letters between the original physician, who was sort of the main physician, Elliot Jocelyn, who took care of people with diabetes. My mother was taken care of by his protege, Priscilla White, the first woman to say diabetic women could have babies. I wouldn't be here if it wasn't for a very particular, transmutation of illness that happened. The other thing, though, important to know about that phrase is that we also discovered what happens as life is extended with diabetes. Now we get to live long enough to have kidney problems and eye problems and all those other things. I've been pretty lucky so far. I've got 35 years under my belt. But the reality is, as treatment changes, you're going to find all kinds of new things are going to happen. And we as healthcare providers have to be prepared to walk that new road. And it's new to us as well as it is to you. So all that fight for new treatments is fantastic. But then there'll be surprises along the way that we probably never expected. But that's where I fell in love with this idea. I like to clarify this just because as I talk, this comes up. When I talk about disease and illness, disease is sort of the biological entity, the thing, the genetic issue, whatever it is that's the root of the medical problem. When I use the word illness, and some people don't like the word illness, people prefer condition, people prefer lots of different things, but just so you understand how I use it, is the psychological and the social meaning that disease has, because it affects how you think about yourself, how you think about your child, how you relate to other people and other systems that you need to deal with. Suddenly, you're a patient in a healthcare system. I was never a patient before. When did that become my identity, right? But so that changes all of those relationships in your life, and your self-concept are really affected by what you're living with, what your child is living with. So, and I generally talk about people living with illness. I'm a social worker, so you'd think I'd use the word coping. I hate the word coping. I don't use it. People don't cope. People live. And they get through their day-to-day life, and sometimes it's only day-to-day. But that's my way of talking about these situations. So I just want you to know my terminology as I move forward. Oh, I didn't mean to do that. There we go. Maybe I should do that. It's like, oh, enough with the slides. But so as our understanding of a disease, as our treatment options change, that experience of illness changes, right? In lots of different ways. And each of you within your disease community could probably tell me what those changes have been. But it changes the experience of illness. It changes how we talk to you as healthcare providers. It changes what your expectations are, perhaps, for your child or for yourself over time. So having treatment, of course, contributes to that transmutation that we're talking about. It may be treatment that manages symptoms, and we know that's not sufficient, but that might be a first step. It may be treatment that slows down the progression of a progressive disease. Again, not perfect, but it's still life-changing. It may change what I like to call the prognosticated outcomes. What's the famous Mark Twain line about the reports of my death are greatly exaggerated? Well, so I had a lot of the patients, I did a study in the last couple years with cystinosis patients who have had treatment for 20 years now. But those children, many of the folks in my study who are adults who are 18 and older, those families were told, your child probably won't survive past adolescence. And they talked about, well, we've all outlived that prediction. And we've gotten there. So that experience for them has changed, and it had to change their expectations. And they had to figure out, okay, well, I'm here, now I got to negotiate the next steps, which is what we'll get to in a minute about transitioning, right? So how does your experience of illness change as treatments change? And this isn't just about talking about adolescence. I'll be talking about adolescents and young adults, but in lots of different ways. Your experience is going to change as we have more knowledge, as we have new treatments. Come on. There we go. I tried to make these big enough. They're crowded with too many words. I'm bad at PowerPoints like this. I keep saying, I just need pictures. There's a great model now. I don't know if anyone's seen Pechakucha presentations. It's 20 slides, 20 seconds each, only pictures. My goal is to someday do that, but I haven't gotten there yet. But the reality is we know that children with congenital problems, chronic illness, rare diseases, disabilities are now surviving to adulthood in ways that probably wasn't expected, perhaps 20 or 40 years ago. Surgeon General Koop in the 1980s was the first person to notice this. I don't know how many of you remember Surgeon General Koop? A few of us? I was in high school at the time. I kind of knew his name. I remember him having a cool beard, I think. He was an interesting looking guy. But he was a neonatal surgeon. And he realized that the children that he operated on as tiny babies were now surviving to adulthood, and no one was prepared for them. The healthcare system wasn't prepared to take care of them. So he pulled together a conference in 1989 to talk with pediatric providers and specialists about what are the things that we need to do to be ready to provide for those patients and help them transition into adulthood at whatever level they could. Some folks have developmental issues or physical issues that are going to get in the way of their independence, but how are we basically giving them the best opportunity we can? This is also the time of legislation when we're talking about making sure that people with disabilities were getting good and open access to education. All of that legislation was had been happening around the same time. So a lot of things moved us in that direction. So he made a big deal that this is not being adequately addressed by the healthcare system. It's been a slow process. In 2002, the American Academy of Pediatrics, the American Academy of Family Physicians, some other folks came together to come up with a consensus statement about how transitioning should work, so that as your children are growing up and moving from pediatric to adult care and from childhood to adulthood, that there were some standards of what we should be doing. And this was their basic definition, which is a great one, to maximize lifelong functioning and potential through the provision of high quality, developmentally appropriate healthcare services that continue uninterrupted from adolescence to adulthood. Has anyone been through transition with their child? Does it live up to this? Not so much. We are still really struggling as healthcare providers to do this right. It's a time of immense changes for your children. It will be a time of immense changes. So who has teenagers in the room? Who has children in the room? Younger children. They will be teenagers, many of them, someday. With your hard work, they will get there. So that age, adolescence and moving into adulthood, immense changes are happening. The healthcare system may be changing for them. Education, so if they're moving from high school to college, what are their needs as they move on to higher education? So what's happening with those IEPs and those 504s? They can go to college with you. You may not know that. Your legal status is changing. I know I've talked with a few people who said, at 18, all of a sudden, I couldn't talk to the doctor without permission. So those legal things have to be negotiated so that if your child wants you to be, and it's appropriate, you can still be involved and help them in their decision making. Insurance changes. Now we have some great things that have happened out of Obamacare and that extension to age 26. That doesn't mean it's easy to do and easy to negotiate, but there are some more options. But if you're on Medicare and Medicaid, there may be other issues. So all of that's important because you don't want that care to be interrupted because of insurance issues. Developmentally, they're at a very interesting point in time, and we'll talk a little bit about that. I didn't come armed with my whole talk on adolescent development. I like to give that to nurses, though, and social workers and docs and remind them because they all forget those basic, like Erickson stages of development and things like that, just to think about where are your patients emotionally, psychologically, socially, while you're trying to dictate all of this medical stuff. And they're hopefully, to whatever extent they're able to, and different kids will have different experiences, of moving into being more autonomous and managing their condition to whatever extent they're able to. And some, obviously, there are broad differences in what that might be. But again, you want to give as much possibility and independence as possible as makes sense for you and your child. I like to share this idea about emerging adulthood. This is sort of a new concept developmentally. Has anyone ever heard of this before? Nobody? Awesome. So I'm teaching you something new. So a psychologist named Jeffrey Arnett, who is a wonderful but incredibly egotistical man, has written, just crazy, just insane, but has written since the 90s and into the 2000s, gaining more attention. There was a big article about him in the New York Times a couple of years ago about this, this idea. And there is now a society for emerging adulthood, so people from all different walks of life, teachers and social workers, meet to talk about this age group in general. It tends to be a lot of research on college students, although we're trying to move beyond that to those that don't go to college. And I managed to get in there 2 years ago to their conference with a poster about cystinosis. And everyone had to stop and go, "What's what? What is that?" And then they had to talk to me about rare disease and young adulthood. So it was great. It was a great strategy. But so this is seen as the age group from sort of 19 to 30, 18 to 30. And that's usually the place around the beginning of that time is when your healthcare system starts saying to you, we need to start thinking about transitioning you to adult providers and adult systems of care. And that is very scary, and we'll talk about that in a minute. But generally, Arnett describes emerging adulthood with these sort of categories, that it's a time of intense identity exploration. Think back to being a college student, being a young adult, right? Intense identity exploration. You're trying to figure out who you are. In a way, and you do that as a teenager too, but in young adulthood, you really often have the opportunity to test things out. Lots of instability, lots of drama, right? Think of the drama of that. I don't like to think of the drama of that period of time in my life, but there was all kinds of where you live, who your friends are, who you're dating, all of these things are all over the place. You're very focused on yourself. I'm trying to figure out who you are. There's a lot of sort of negative talk about emerging adults in employment situations because they're kind of demanding and needy. The millennials get a lot of bad press about this. But the idea that, well, we expect to get some training. We're doing this so we can learn to be better at our jobs as we move forward. So we expect to be catered to a little bit. It's also a generation, though, that does an immense amount of volunteer work and connecting. Some of it's for selfish reasons, but some of it's for very generous reasons. So it's a period of time, though, where that focus on self, I got to focus on myself because I got to figure out who I am and who I'm going to be. But they're also caught because they're not quite adults yet. They're not kids anymore. They're not teenagers, but they're in between. My cystinosis patients that I know, one of them he said, "I'm an incomplete adult. I'm not quite there yet." I love that phrase. Because they really are stuck. So they may come, something bad happens, they're going to come running home to mom and dad. Say, I need your help with this. On the other hand, they'll try to do these really brazen and adult things. So they're really in that in-between sense. But there's also this immense sense of possibility, that I have the ability to become someone new. I can look forward to the future, think about what I'm going to do as a job, what my family might be like. You can envision those things. Now, obviously, no, that's not what I wanted. For people with rare disease and chronic illness of all different sorts, I fully believe and I see that some of those things are constrained. You don't get to explore in the same way. You might not be able to be healthy enough to move away from home, to try out those things that allow you to test out your autonomy a little bit. There may be lots of things that don't happen as easily. My argument would be, it's still a good yardstick to sort of use to think about what am I able to do, what is my young adult able to do in order to explore who they're going to be as an adult. So 20 years have passed, more than that, since Surgeon General Koop started talking about transitioning. It is a hot topic at pediatric conferences. I go to a lot of pediatric nephrology conferences. This work and research has taken me to amazing places. Like I got to go to Shanghai. I never experienced in my life that I would go to Shanghai. I'm a social worker in a hospital. But it's a hot topic. We talk about it. I talk about it endlessly, but I've been talking about it endlessly for 15 years now. No, we've made some progress. A lot of hospitals, so some hospitals and medical centers have wonderful transition programs where they start talking to patients and families early. They provide a lot of support to be able to do that. Others, not so much. There's also a lot of tools out there to help you figure out what supports you might need and where your child is in terms of their independence. So there's a lot out there, and we talk about it a lot, but there are lots of problems. Can you hear me if I whisper? There's a lot of inconsistency across institutions. So from one institution to another, we do things differently. My own institution, where I've been like preaching about this for 15 years, we're still trying to figure out. Individual specialties have their own approach to working with their particular patients, but there is no unified policy across the board. We have people doing research in this area, and they don't talk to each other. My big success is we started a work group, and every 3 months we ask everybody that's doing transitioning work to come together and talk to each other. But it's really challenging across institutions, and even within institutions. We surveyed all of our pediatricians within my urban healthcare center. There's about 300 of them, and about 100 of them deigned to participate in our survey. There is such inconsistency in what people do. We also know that there are some particular challenges, and you probably may all know this better than I do, for patients with rare disease. There's those inconsistencies across institutions. There's a lack of experience, and I think this is common, right? That providers don't know, and you do wonderful jobs trying to educate them and pull them into your community, but you may have a limited resource, even within pediatrics. And there may be very specific things for your illness, your disease group, and how that affects your child's needs and your child's development, and that needs to be appreciated. There may not be a great accessibility to adult providers who either know about your disease or who are interested in learning. Here's the biggest problem. We have a marketing problem because we have to convince adult providers that these young patients who are coming to them are not needy and demanding, because those are the words that the adult providers use, that they are interesting, that they are engaging, and they are in the same need of support of someone who is 32 and gets a new diagnosis, or 65 and gets a new diagnosis, or has a long-standing chronic illness. Adults are pretty needy and demanding all along. So I don't know why our pediatric patients are seen differently. I really struggle with it, but I think it's a marketing issue. You also have these amazing long-term relationships with your physicians. You may have met a physician at that moment of diagnosis and have worked with them throughout your child's growing up. And now you're told you have to leave them. That is terrifying. Sometimes it's a relief, like, all right, I've had enough of you, and it's time to start afresh. And I think sometimes that fresh start, just like starting a new relationship and identifying, like, no, this is who I am. Sometimes that's actually a good process, but it can be very frightening. And the docs hold back on moving people onward, and families are resistant and they don't keep appointments, or they struggle with, no, I didn't vibe with this person, they don't really give them a chance. So there's difficulty on both sides about letting go of that relationship and being able to trust this new team. You have to take a leap of faith and go, okay, I'm going to put my trust in these people. And hopefully you found new adult providers who are saying, if I don't know, I'm interested in learning. I'm interested in coming to your conferences. I'm interested in reading all your materials. I'm going to reach out for those things. But that takes time to develop. It doesn't happen right away. And you need to really be literate and knowledgeable about the condition so that you're talking, be able to speak reliably. And you will hit up against people who feel like they know better. I know I've heard this. I was saying earlier, my picture didn't make it into the book for the event, and I'm kind of glad, because I've gotten to stealthily walk around and listen to people, and no one knew who I was, to hear some of your stories. And I know that it's frustrating to have to teach new providers, but the more that you know and are able to go in armed with knowledge and history and that big book of your lives, that engages those new providers. And we struggle, this is not just in rare disease, this is across transitioning in general, that communication is really challenging. How does information get shared? And I'll show you some of the expectations that we'd like to have providers do, but the reality is it's difficult. We're all sort of putting our hope in the electronic medical record that somehow at least like consistent information will be there. That's not enough. But that's one way of saying, at least I know that my new provider is looking at what my previous provider has done over the years. They have access to that information if they choose to use it or not. I'm like flinging all over with the laser pointer, aren't I? Skip that for a minute. I want to talk about this. So these are 11 steps of healthcare transitioning that we are talking to providers about. So some of these come from that 2002 consensus statement that I talked about. There was also an update to that in 2011, a clinical report from the same group that included an algorithm for how one should transition patients from pediatric to adult care, the things that were important. A colleague and I are doing some research. These are the steps that we asked our pediatricians about. How many of these are you doing out of 11? We were lucky if we got a few people that got up to 7. Most folks fell around 4 of these items. So the idea that this is things that you do with your patients and families, that you make sure that your patient has basic knowledge and skills to take care of themselves, that there's someone on your team that focuses on transitioning and helps make sure that information gets conveyed, that appointments get made, that you actually introduce them and identify and connect with an adult provider who's going to step in. So that isn't a sudden, okay, tomorrow you have an appointment with so-and-so, but that there's some connection made between those two providers. Sharing all kinds of information, a medical summary that you have in your hand, that you have in your binder, that you have on a USB drive. I saw this at a meeting last week, a couple weeks ago, that it's just a card you buy that has a USB in it, and you dump your medical records onto it and your information, and then you walk into any emergency room and you go, here it is. Don't leave without it. Like me, I leave my USB drive everywhere. Copies of my dissertation are all over the country because I leave it behind. But so all that data. An emergency plan. What do you do if you get sick and you're not near your center? This is especially important if your kids are going off to college, they're starting with a new center. Well, maybe you figured out where they're going to go and who they're going to talk to. But if they end up in an emergency room for something different, what information do they need? What do they need to do? Or what happens if the lights go out, there's a hurricane, there's no power, what do you need to do? Like, all of those things need to be thought of ahead of time. Some of it you might have been doing for years. Talking about the legal aspects of transition. So what consents need to be signed so that folks can, if you want your parents involved, that systems have permission to talk to them, that you have permission if you need to say call your child's college and things like that, that you have permission to do that. We also make sure things like end-of-life decisions at 18, patients can sign those for themselves if they're cognitively able to. In my hospital at 18, we ask everybody, do you have a living will? Have you thought about those things? Can we help you get that done? Because everyone should have those, right? All of us. How many in this room have some sort of living will or other document? Not all of us. It's really important for everybody. We talked a little bit in one of the breakouts this morning in the deep dives about who the doctors talk to. And in transitioning, we really want to stress that we're talking to patients and families together, but that we are also taking time to talk to these young adults as teenagers alone, even if it's only for 10 minutes. Because, one, it's respecting their privacy. There may be things they want to talk about not in front of mom and dad. They have a right to talk about those things. There are reproductive health issues. There are all kinds of adolescent behaviors that maybe they wouldn't talk about in front of you that they will if the doctor has some time or the social worker, the nurse has some time with them alone. It's also teaching them a skill that they have to be able to talk to their healthcare team independently, because otherwise, if you don't, that's a skill to be learned. That doesn't come naturally. So that sense of, can you step out of the room and give them that choice? And is your doctor asking, I want to spend a few minutes, on our own before you leave for the day, just to make sure that, there aren't any questions or anything to talk about that we've missed. And making sure they have ongoing routine care while all that's going on. I make a big fuss, especially about reproductive health care, because I think often with kids with chronic illness, we forget. We think, oh, their lives are so constrained and they're not going to do those things. And well, you know what? They will do those things. My renal patients surprised me in the things that they did. And the boys especially like to tell us about it. So it's really important that we as healthcare providers and you as parents feel comfortable that those things have to be included in your conversation. And of course, as teenagers are moving to adulthood, they want to be asking about things about childbearing and things like that. So that has to happen too. All right, I'm being told I have to. Oh, I'm running out of time. I've got two quick suggestions. So for parents, there's lots of advice out there, and I'm going to give you some resources in a minute. But find out your institution's policies. When we start, you'll get some advice on specific things to do with transitioning. Start early. Anne, where are you in the room? We had a conversation the last time we were together about her son who has AHUS, and we were talking about starting to do things independently. It was as simple as filling a pill box, taking one medication on his own. He's 10, right? But it was one step. She's got hopefully 11 more years to get him on the road to independently taking care of himself. So that's one little step. These are baby steps. But starting early, and it may be hard for you to envision doing this. You're like, my kid's not ready for that. It's possible. Find out your options. If your team doesn't know, if you're not in a hospital setting that has sort of a transitioning program, start asking questions and start finding out what you can do and talk to your fellow parents. And there are wonderful readiness tools out there to see where is my child in this process of becoming independent. I'll show you one of them in a second. But since I'm in a room full of advocates and advocacy associations, I want to think a little bigger than that. So what can you do as an organization to help as your patients are moving to adulthood? So make sure that you're thinking about that especially as treatments change, and maybe think ahead a little bit, or as we just get really lucky, whatever happens, that our patients are now getting to be adults and moving onward to adulthood. Are we paying attention to that within our community? Be attentive to those folks. Start making connections. So if you find an adult provider who's fantastic, make sure the rest of your community knows about that person. They will get deluged. But then maybe they can help other providers, but you can identify those folks so that then you have a group of people that you can turn to who have expertise in your disease area. As those folks become adults, make sure that they're getting into positions of leadership in your organizations. Because many of your organizations start out as parent-led organizations who are doing everything they can to keep their children healthy and alive. But as those folks survive, you have to be willing to cede some power to them so that they can become involved and share their experience as a patient, which may be different than your experience as a caretaker. And one of the most important things that I think, and I could talk about this for another hour, and I won't, is the idea of peer mentorship. That as you have teenagers and young adults in your communities, they want the opportunity to give back and say to those younger folks, I was there, I did that, here's what worked for me. Adolescence particularly is that age where adherence to a lot of treatments is really problematic, right? And that puts our kids at risk. They've got great advice on how they survived and how they did it, and they want to share that information back. So find ways within your organizations to create those structures for peer mentorship. All right, I'm done, but I'm going to show you. This is gottransition.org. This is one of many tools for readiness. They have lots of resources on their website. This is from it was the Maternal and Child Health Bureau. It's now changed its name to be about adolescence, but they have wonderful tools that you can use with your teams, that your teams can assess how well they're doing, and that you can look at how ready is my child. This is my big news. We're very excited about this. Thank you, Global Genes. This is the new Global Genes book. They have a fabulous website as well. Ilana and Katie, are you in the room? I think they're outside working. But we just put this together in time for this meeting with all sorts of suggestions for you and really geared towards young adults in the steps they need to take to become more independent. So I believe, do we have it outside, guys? Go get them and then come back and talk to me. All right, I'm going to shut up because I want to, and on my slides when they come out, there are some other resources and links and other things. Do people have questions, or do you want to tell us about your transition experience if you've had it? Do we have time? Excellent. All right, 5 minutes. Let's use them. Come on, somebody be brave. Yeah?
There wasn't any.
Hmm?
There was no transition.
There was no transition. Tell us what happened.
Hold on 1 second. Tried to even find a doctor. They said you just have to go into the computer and pick one. I said after all these years that you're telling me to just do that?
Yeah.
And we had to just pick whoever was a new doctor no matter what. And there was no transition. There was no transition from one pediatric oncology infusion center to adult
Yeah. It's a
infusion center. None.
It's a big problem.
It was
And
horrible.
so what really has to happen, and I kind of have to put the pressure back on you all. You can't wait until they say it's time. You can't wait till 18 or 21. It's important. Find out the policy at your hospital. Like my hospital, we keep kids till 21. Other places keep them until 16. So you need to find out up front what's the policy. And if they don't have a program and they don't have resources, you can start early to look, to see who's out there, to talk to other members of the community. It's not a perfect answer for everybody, but you have to start well before you reach that moment in time. Because there's a transfer of care, that's not a transition. That's just a transfer of care that happens the day you go to that new appointment. But the idea of transition is we have lots of time, hopefully, to get you ready psychologically, practically, legally, so that when you move to that new system, you're ready. But it is highly imperfect, and that's why, and I always say back to families, and I've been saying this for years, unfortunately, you all have to, as in many other parts of your lives, you have to be the advocates. I'm sorry to tell you, I don't have the magic, like, wait, I've made transition better. You all, or many of you, will still be in the position of having to do that research. Other thoughts? I am around for a couple hours this afternoon, and then I'm around tonight. I'll be at the Margarita Hour and Bonfire. I would love to talk to you all, so please come and find me, and if I can connect you to other resources, I certainly will. Thanks, guys.